I will be speaking in English moving forward after my bonjour. My talk is going to be a little bit different. We've focused on a few specific areas in healthcare, and now I'm going to talk about the big picture as it concerns adults with developmental disabilities, not syndrome or etiology specific. The program that I direct in Toronto, the Healthcare Access Research and Developmental Disabilities Program, is actually a provincial program. So on a map, I'm not sure, we have 13 million people in Ontario, so I'm not sure how that compares in size to France. We're mostly located in more urban and more southern parts of our province. But this project brings people together from a number of universities and hospitals, and also partners in government, and also advocacy agencies or associations. And that's important because, well, I'll tell you a very fast story. I was presenting my research maybe about 10 years ago, and I was talking about the great research that I was doing, and a very bold father stood up and said at the end, after all is said and done, a lot more is said than done. Reminding me that, you know, we can have our research, but if we don't work together with clinicians and with people in policy, it's difficult to change practice. So that's how we do our work in this project. Okay. So first, I'm going to speak about the evidence, and I'm going to summarize a project that took about 5 years from start to finish in about 8 minutes. The summary of the findings, if it's difficult to understand what I'm saying today, are also in French, and so you can read those after the presentation. But together we looked at all adults with developmental disabilities in Ontario, because we wanted to know which areas of healthcare do we need to improve, and the only way to really know that is to look at the numbers. So what we did is we tried to identify who has a developmental disability by looking at diagnostic information from their health records. So in Ontario, if you go to see your doctor, the doctor writes down your diagnosis when they bill, when they get paid for the care that they give you. So we looked at all of that information across the lifespan for Ontarians to see who has a developmental disability, recognizing that it doesn't always get recorded. So we also looked at the information from social services. In Ontario, if you have a developmental disability and you're an adult, then you get income support. So you get money to help you live every month, and you also get your medications paid for and other sorts of benefits. So the red circle shows us who has a developmental disability that we could find from their doctor's billing information, from their health data. And the blue circle showed us who we could find with a developmental disability according to income support or social services data. So the first thing you see is that they don't overlap perfectly, that there are many people who are only identified in one sector or in the other sector. The other thing you can see from this is that we studied a very large group of people. So we were able to talk about healthcare for almost 67,000 adults with developmental disabilities. Okay, so I'm just going to show a few of the findings from that project. This is showing you on a map, every dot represents 5 personnes. And you can see that they're all over our province, mostly situated in large, so the most dense area is Toronto, and there's Ottawa, where they speak more French than I do, and some other areas around Toronto that are more urban. But in addition to looking at where they were, we also found, because we could look at their income, and we could look at if they were in rural or in urban settings, that as many people lived in urban settings and rural settings as people without developmental disabilities. But the people with developmental disabilities were more likely to live in poverty, in poorer neighborhoods, not surprisingly. But that's important because we know that poverty is related to health and healthcare use. So this figure shows us rates of different medical conditions for people with developmental disabilities and without. And so the developmental disabilities are in blue, and without is in red. And right away you can see there's a difference for almost all of the health conditions that we studied. The one that's most obvious is the last one, psychiatric disorders, where you can see that in a 2-year period, almost half of adults with developmental disabilities received a psychiatric disorder diagnosis, compared to about 1/4 or 26% of the general population. But other areas like asthma, diabetes, chronic obstructive pulmonary disease, and congestive heart failure are also occurring much more frequently than what we see in the general population. When we put all of it together, so we look at multiple conditions or comorbidities, we see that people with developmental disabilities are more likely to have many health issues at the same time compared to people who do not have developmental disabilities. So we were also able to study all the health services that were used in a year for both our group of adults with and without disabilities. So interestingly, the first column looks at primary care or seeing your family doctor. And most people with developmental disabilities go to their family doctor at least once in a year. So that's not where the problem is. And if we look at the average number of visits that they have, it's fairly similar to what we see in people without developmental disabilities. But when we look at their emergency department use and also their hospitalizations, we see a difference between the two groups. And we also see a difference in terms of the average number of times that they would use those services. So this tells us that even though they're getting some primary care, the quality of that care maybe we need to look at, because they still need to use these other types of services for their complex health issues. Okay. One thing we were able to do just for those with developmental disabilities, so for 52,000 of the adults who were getting the income support, we could study what medications they were taking. We couldn't compare that to people without disabilities because in Ontario, if you don't have a disability, you pay yourself for your medication. So we only can look at people with disabilities. So this figure shows us that 39.5% of the adults we studied were not taking any medication. Okay? But the majority of people, so more people, were taking at least one, and maybe more concerning is the number of people taking 2 or more medications, including about 20% of people taking 5 or more medications plus at the same time. So the question is, what types of medications were they taking? And I'll try to go through this slowly if we have to translate what the medication classes are. The red bars are for psychotropic or psychiatric medications, and the blue bars are for medications for medical conditions. So the most commonly prescribed medication in the population, so not just in a clinical sample, but the whole population of 52,000 adults under age 65 were antipsychotics. And as perhaps you know, yes, psychotic disorders are more common in those with developmental disabilities, but not that much more common. They're often prescribed for behavioral issues. And the other medications that are prescribed frequently are also for psychiatric issues. A doctor told me that one of the reasons why some of the other medications, so the proton pump inhibitors for reflux, is actually a side effect of what the patients are sometimes getting from their psychiatric medications. The other one near the top, looking at laxatives and constipation, is something we've already heard about today around pain, and I'll talk a bit more about that later. Okay, so we were able to look at the kind of care, the quality of primary care in those with and without developmental disabilities. And what we see here, this is the periodic health exam is the checkup, where we go from head to toe to look at general issues. And guidelines would suggest that it should happen once a year. Here we're looking over 2 years, 2 années, and you can see that people with developmental disabilities are not getting those exams very frequently. We would expect not only that it's the same as the general population, but it should be higher because of all the potential health issues that they have. And there's excellent research that's been done both in the UK and in Australia showing us that that exam is a very effective way of identifying conditions early and preventing disease. I'm going to show 2 slides on cancer screening. This came up earlier. This is looking at colorectal testing. And at different ages, we see the same trend where those with developmental disabilities are much less likely to have the screening than other adults. We see a similar pattern when we look at mammography or breast exams. And interestingly, in people without developmental disabilities, the lower your income, the less likely you are to have a mammogram. But in those with developmental disabilities, it doesn't matter where you live or how much income you have. You're equally as likely not to have the exam. Now this looks a little different. You say, oh look, the blue is bigger than the red. But this time we're not looking at an exam, we're looking at avoidable hospitalizations. So for example, constipation, you should have that managed at home and you should be able to see your doctor and you shouldn't have to go to the hospital. Diabetes, you should manage that in primary care. You shouldn't have to be hospitalized. And what we see is that hospitalizations that we should be able to avoid are much more common in those with than without developmental disabilities. This is looking at how often people with developmental disabilities see their doctor for medication checks. So we don't know what happens at the visit, but we can count how many visits they have in a year. So for those who are taking 2 to 4 medications, about half of them do not see their doctor at least 3 times that year. And for people taking 5 or more medications, there's still a third of them, 1 in 3, who is not having at least 3 checkups that year to monitor their medications. So that's very concerning. Okay, so there's some evidence of healthcare issues. How do we change that? We have guidelines, and we've heard a number of guidelines already this morning. We heard about pain guidelines, we heard about sleep apnea and Down syndrome, and also a lot of sort of rich clinical guidelines or ideas, first thing this morning from Dr. Ravel around things we should look at with all of our patients. But it helps when those guidelines are written down and everybody reads them. So we published guidelines in Canada in the Canadian Family Physician, so that's the journal that everyone reads who is a family physician, of primary care guidelines. And these are them in French, so you can just download them and read them. This is actually the updated guidelines. We wrote them first in 2006. We revised them in 2011. And every Canadian family physician was mailed a copy of these guidelines in the journal. They highlight what the issue is, the consideration, and then what the recommendation is. And then the last column is the level of evidence for that recommendation. So some recommendations are based on, trials, the best level of evidence we can find. And sometimes the recommendations are based on consensus or clinical opinion. The first set of guidelines look at general issues. So I highlighted the idea of having that preventative periodic health exam every year. Then we have physical health issues guidelines. So here I highlight the cancer screening guidelines. They're no different than the cancer screening guidelines for the rest of the population, but because we forget to do this for people with developmental disabilities, we put them in the guidelines to remind people about screening. And then at the bottom, we have guidelines that are about managing mental health and behavioral issues. And each of the guidelines were developed by people with sort of the most expertise in that area. So this example is looking at when someone has a crisis, a behavior crisis, and they go to the emergency department, they need to have follow-up after. So we need to see them at the doctor's, do some more crisis planning, and think about next time. There's also information about medication use. So some people think the high level of antipsychotic medications, in part, is because at the hospital in crisis, they're prescribed tranquilizers, and it's really just for crisis, but they stay on them forever. Okay. So we gave everyone the guidelines across our country, and we patted ourselves on the back. But the truth is, it's not that easy to implement guidelines. So I'm sure many of you have guidelines that you don't remember to look at. So we've also developed different types of tools to help people use the guidelines. And I brought them. These ones are just in English, but on the website, they're also all in French. And so I'll explain a little bit about what they are, and you can look at them after. So these are the websites that have the information. If you forget all of this, or you can't write that quickly, just write down hcard at the top, .ca, and you can find all of the links. So the way we developed the tools is we were teaching about the guidelines, and people said, well, I don't know how to do that. How do I set up a health exam? So we had to talk about ways to make the patient more comfortable, the time of day they might want to do the exam. People said, how do I deal with the tranquilizers in the hospital? So we made a tool that helps them think about, if they're doing tranquilization, what to consider. How to get patient consent. So we spoke with clinicians who said we can't do the guidelines, and we helped them figure out how to do the guidelines with the tools. So here are just some examples of tools. This first one, the way it looks, it was purposely designed to look like the forms that they're already using in their office for other patients. So they're electronic, they can fill them out online if they need to, and they go right into the patient chart. You can see it's reminding us things like how we would communicate with the patient and special considerations, who can make the decisions. That's very important to be right on the front page. And also issues about how the patient might respond to the exam. So sort of big picture issues that help you do proper care. This is an example if you're seeing a woman, which preventive care issues you need to look at. And some of them are highlighted in pink. And that's because these issues are unique or a little different than what you would do for your patients who don't have developmental disabilities. And again, this form is modeled after the form that doctors are using for all of their other patients. So it's very familiar to them. We tried to make it something that they could use because they already know how to use it. Okay, this is just an example of a discussion. It's Ontario specific, but it talks about issues around consent with the patient. Okay. One thing we did, and I put Down syndrome down because of the meeting that we're at, but we have a number of Health Watch tables that go from head to toe, reminding us for different syndromes which considerations to think about in terms of an exam. And each one is not very long, maybe about 3 or 4 pages. So we have it for Smith-Magentis, Down syndrome, Fragile X. There's a new one that's for autism. And there's probably about 2 more that I can't remember at this moment. But getting the doctor to have the tool is one piece, but we also need to get the patients and the caregivers to have tools. I'll give you an example. One tool we made for mental health and behavior issues, we gave, it was 5 pages in length, and I helped write, I wrote, part of it, that's my area, and I thought it was great. But the doctor said, I will never ask all these questions. I do not have time for this in my visit. I need the information when the patient comes in. So we split it into the piece that the patient and the caregiver fills out first, that they bring in, and then a smaller piece that the doctor looks at themselves. We need to empower patients and families and staff to also give information. So here's just a few examples of some of the tools. This tool is a very easy read way for a patient to say, this is why I'm coming, these are some issues that I have, this is what makes me comfortable, so you can treat me well, and these are concerns that I've noticed in the last week. And the idea is that the patient would take their time to fill this out beforehand. It's similar in some ways to a health passport. We have another one that's specifically for emergency department visits. Again, a lot like some of the health passports you might be familiar with that are used in the UK, but specific to the type of visit that the patient is having. This is an example for the caregiver of information they would try to track about behavior to help the physician understand why there are behavior problems and what is triggering those problems. And this is just for fun because it's lunch coming up soon. I mentioned constipation. Again, it's a very serious issue in this population. And if we want the patient or the caregiver to monitor stool, they have to know what it looks like. So part of this is not just the pictures, but it's the chart where they're documenting when they go to the bathroom, what happens, what does it look like. And you actually need to show some of these pictures or they really don't know what it is they're supposed to be reporting. Okay, so we have our evidence, we have our guidelines, we have our tools, but it's still not enough to change care. We need to think about how we put the tools into the practice. So a very important piece is actually listening to what people in healthcare say about how they do their work and where they do their work, how they find their information, and also how they feel about the patients that they're working with. So a lot of the work I do is with the emergency departments. And when we first go to a hospital, they always say, we don't see any patients with developmental disabilities here. And then you explain what it means, and then you start to listen, and you always hear a story of at least one patient who's come 50 times again and again and again. And the hospital does not know how to manage them any differently, so they just come back. And when you listen to the stories, you start to understand things like they're very uncomfortable giving the disability a name. So they don't write it down in the chart. They don't write, I suspect there may be, an intellectual or developmental disability. And that means that the next time the patient comes in, it's still not in the chart. Or you hear, I'd like to do this work, but I don't know how, and someone else must be able to do it. So can we just give it to them? So there's a lot of teaching we have to do once we understand how they're feeling about the patients and what kinds of stories they tell us. This is just an example. This is in the Atlas. Actually, this is Dr. Bill Sullivan, who was the lead author on the primary care guidelines. And we put this picture in because of the quote below, but also because when we're trying to speak to clinicians or policy people to explain what some of these numbers mean, we can't explain them without pictures and without stories. So we're using how we explain our information to enhance our research or help to make changes. This is another way we're trying to put care into practice. We want to train people to do different care, but nobody has any time to do the training. So we created very short video vignettes, working with people with developmental disabilities as actors and with healthcare professionals, highlighting standard practice so people don't have to be embarrassed that they don't sometimes know how to manage difficult situations, and then showing a second vignette of how it could be done a little differently. And these are right on the computers of the staff in the hospitals, so they can do it quickly and get credit for it, but we don't have to bring everyone to a training for a whole day, which can be very expensive. This is part of a sort of a campaign for public awareness. I know there's a lot to read in the pictures, but what's important is that these are real people from Ontario, and the first thing they tell us is who they are and something kind of special or interesting about them. Then they tell us something about when they go to the doctors, things that they would like or things that are important. And if these are posted, around the healthcare setting, it makes them feel like they belong in that setting, and it also reminds doctors and other healthcare providers about the full lives of their patients. So we often see people in the hospital or at the doctor's office at their worst. And we forget, we're focused always on the problems, and we forget about the other aspects of them. And so this is a way to remind people about how to think about the population. This is just illustrating that we might have information and somebody will like it as a research article. Somebody wants a little booklet or some tools. Someone wants a whole big binder with everything. And then we hear in another setting, I will never look at that binder. So the last picture is a one-pager for the doctor in the emergency department, because that's all they're going to read. And so when the patient is flagged as having a developmental disability, that one-pager is put on the chart on the clipboard, and the doctor sees it just to remember a few things they need to do. And this is an example in one hospital to change care. Everything they do is electronic. And the only way they're going to remember to work with this population differently is if it's flagged on this dashboard. So you can see right there, they're a DD Cares patient. So they know we have to monitor these different things for this patient. And it electronically in the computer, it tells them different things they need to start doing because of the suspected disability. And then these are examples we heard in one hospital that it's too much to expect to write a letter at the end of the emergency visit. So we said, okay, there's some basic information you have to give. Can we just have a quick form that populates itself from information you already put in the computer with a few more pieces, and can it print out a letter that goes to the patient? Because the patient needs to understand why they are in the hospital and what they need to do for follow-up, and we're not giving that message in the way we're providing care now. So just to end, we're in France, and the food here in Paris is delicious. So the ingredients, if we pay attention to changing our healthcare practice, we have to combine our evidence or our data with aids and tools and instructions or guidelines on how to do things. But we also need to get a lot of people talking the same language. That's the critical mass piece. So our group has grown probably about 10 times the size of how we started 10 years ago. And we also need people to buy in, and we need to have policymakers and families working together with us to make that change. So, And these are the links to the different resources that I spoke about in French and in English.